So I'm going to go ahead and get the ball rolling. We have a very interesting topic to discuss today, and we have a great panel to my right. In order to have time for us to have a good discussion, feel free to move up. We've got some room here. We're going to have each panelist introduce themselves when they approach the podium, starting with myself. I'm LaWanda Grisette, Director of Advanced Heart Failure, Professor of Medicine, Miller School of Medicine. So my disclosures are this, and I'm going to begin the day by discussing, so why are we talking about a new device therapy for patients with NIA class 2 to 3 heart failure when we live in this era of unparalleled success of pharmacologic therapy in heart failure? So in 2023, we have so many highly effective therapies that sometimes we actually have a hard time getting them all on board. And this slide demonstrates that with the exception of the ACE inhibitors and the ARBs, which started it all off, each therapy that's shown a mortality benefit has been on the background of existing GDMT. And each of these therapies has demonstrated incremental benefit with MitraClip and the SGLT2 antagonist bringing up the rear most recently. So in 2023, we live in this era, we had the triple drug therapy, which lasted for about 20 years. Now we're living in the Fantastic Four generation, which is how we refer to it in the US, which kind of reveals how much time we spend thinking about Marvel movies. And I understand that in Europe, this is referred to as the pillars of heart failure medication, and you can insert your own cultural comparison joke and or witticism for that. So regardless of how we call these medicines, regardless of the sobriquet, the combination of all 4 drugs is extremely potent. And in this analysis, which is a pooled analysis meant to estimate the combinatorial efficacy of different iterations of heart failure medications available currently, we can see that with the Fantastic Four, ARNI, beta blocker, MRA, and SGLT2 antagonists, there is an estimated theoretical 61% risk reduction for all-cause mortality. So that translates to about a 5-year of life gain for the average 70-year-old patient with heart failure, which is amazing when you think of where we came from in heart failure therapy. So with therapy this good, where are the remaining challenges? Well, it turns out that 4-drug therapy isn't being achieved quite as often as we would like or prefer. So this is a central illustration from a study of nearly 300,000 patients from the US, Japan, and Sweden, and progress from initiation to dose titration with follow-up at 100 days after initiation of drug and at 1 year. And if you look at the central panel, you can see that with the US on the end, at 100 days, about 10% of patients aren't on any heart failure medications at all, which is striking. If you look at Sweden and Japan, they do slightly better than we do, but still nowhere near ideal. And if you look at where we are at 1 year, it actually gets worse. So 1 year after GDMT initiation, target dose achievement, which is represented in traffic light green, versus discontinuation, which is represented in traffic light red, you see far more green than red for every class of medication. And if you're questioning, as I did, well, how much of this is related to appropriate discontinuation of ACE and ARB for institution of ARNIs, that's actually represented by these thin blue lines that we see in ACE and ARB. And there are many reasons why patients may become intolerant to one or more of these drugs by the end of a year, and I don't have to talk to this audience about why, But I think that the take-home message from this slide is that the 4-drug combo, as impressive as it really isn't available to all of our patients all of the time. So what does that mean for our patients? When we look at their ubiquitous natural history cartoon, the highest activity for heart failure patients in terms of what happens to them, their symptoms and decompensations, is at the beginning and toward the end of life. And while with today's amazingly effective therapy, some patients may start on GMT and have near remission of symptoms, most eventually progress along the downward trend. Patients in that great in-between of not recovered or remitted and too well for advanced heart failure interventions remain symptom limited, class 2 and 3, and patients in these categories will suffer from debilitating symptoms and poor quality of life, as we know. 76% have difficulties with usual activities. A similar number have mobility issues. 24% struggle with self-care, which is also emotionally devastating, so it's not surprising to know that 50% suffer from anxiety or depression related to their limitations. And while no one questions that GDMT improves heart failure morbidity and mortality to a degree not even imagined 20 to 30 years ago, there are still gaps, opportunities, and more that we can do for our patients. So we look at quality of life, despite the fact that GDMT is so effective in reduction of mortality and the morbidity of heart failure hospitalization, is actually not as impressive when we look at actual quality of life. And as powerful a drug as the ARNI is, Entresto, in the Paradigm registrational trial, quality of life didn't actually improve. It's just that quality of life for patients on Entresto was less bad than quality of life for the patients on the active ACE comparator. When we look at exercise capacity, the benefit of GDMT is also quite modest. Now, CRT, another effective intervention, does offer robust benefits in terms of exercise tolerance as well as quality of life, but unfortunately, CRT is indicated in less than 30% of heart failure with reduced ejection fraction patients. And as we know, even for those patients for whom it's indicated, and by some analyses, that number may be a lot lower, closer to 15 to 20%, and 30 to 40% of the patients who are implanted won't necessarily respond to the therapy. So where else can we look? So we've clearly enjoyed, and our patients have enjoyed, the benefits of neurohormonal modulation. What about neuromodulation? We know that the autonomic response in heart failure is abnormal. Afferent signaling from chemoreceptors, metaboreceptors, and the renal nerves all contribute to the vicious cycle of heart failure. And baroreflex control, highlighted in blue, is of particular significance because when you look at the baroreflex actually are the primary mechanism for autonomic modulation of the ANS in terms of sympathetic activation and RAS activation as it pertains to the heart and cardiovascular homeostasis. The downstream result of decreased baroreceptor signaling are adverse physiologic changes familiar to us all, such as increased heart rate, increased remodeling, increased renin secretion, and decreased diuresis, and inappropriate vasoconstriction. It's also known that the baroreflex activity is impaired in heart failure specifically, which results in the pathologic imbalance in sympathetic and parasympathetic tone that we're familiar with that underlies many of the symptoms, the worsening symptoms associated with heart failure. Now, the rationale for the Barostim device is that If the baroreceptors are essentially impaired by heart failure and activity is less than desirable, why not use Baroreflex activation to increase sensitivity and thereby decrease inappropriate sympathetic tone, increase parasympathetic tone, leading to a reduction in symptoms. So the device itself, the elements are a single carotid sinus lead that's implanted extravascularly to the carotid artery through a small incision in the neck, similar to the access used for an endarterectomy. The lead is tunneled over the clavicle and connected subcutaneously to a pulse generator, which is about the size of a normal pacemaker and is placed in a standard pacer pocket. Procedure takes about an hour or less, and most patients go home the same day, and there's no intravascular or intracardiac hardware, importantly. So I'm going to conclude with making a few points. One is that despite amazing contemporary GDMT, there's still treatment gaps in the treatment of our patients with heart failure. The patient tolerance of and ability to comply with GDMT is not ideal. And there's still excess mortality in this population, even in the face of complete GDMT. Exercise capacity and quality of life remain poor. And Baroreflex Activation Therapy is a unique opportunity to work through recalibration of sympathetic and parasympathetic activity in the autonomic nervous system. It's a novel option for patients with persistent class 2 to class 3 symptoms and a narrow QRS. And the safety and efficacy of Baroreflex activation is supported by randomized clinical trials with long-term follow-up. And I'm going to hand the mic over to my colleague, Dr. Howard, who's going to give you that data. Thank you.
Thank you, Dr. Gazette, and thank you, distinguished panelists and audience members, and thank you to the sponsor for organizing this symposium. So I'm a heart failure cardiologist in Atlanta. My name's Dr. Brian Howard, and I'm going to spend a few moments talking about the data and the results behind the BeAT-HF trial. Here are my disclosures. So I'll start off by discussing the results of the pre-market phase of the BeAT-HF trial, which led to FDA approval, and I'll frame these results in the construct of the post-market phase, which were recently presented at THT by Dr. Michael Zeil. I'm also going to spend some time talking about the win ratio analysis and how it applies specifically to the outcomes described in the BeAT-HF trial. So BeAT-HF was a prospective, multi-center, randomized controlled clinical trial. The study was deliberately designed to have two phases, again, this pre-market phase and a post-market phase. In the pre-market phase, patients were optimized on medical therapy and ultimately stabilized for at least a month prior to randomization into the medical arm or the Barostim or BAT plus medical management arm. At 6 months, multiple metrics were analyzed, including 6-minute hall walk, NYHA functional class, quality of life as defined by the Minnesota Living with Heart Failure score, NT-proBNP, and safety. The strength of the data using these metrics led to FDA approval in August of 2019, and ultimately 264 patients were included in this final pre-market analysis phase. And those patients were then followed on with time for the post-market analysis phase, looking at longer-term outcomes of cardiovascular mortality and heart failure morbidity. The key inclusion criteria for the BeAT-HF study are listed here. In particular, patients had a NYHA functional class of 3, and the LV ejection fraction was less than or equal to 35%. The BeAT-HF results in terms of symptom improvement were strong and consistent. Looking at exercise capacity here, and just to orient you on the chart, the far left is the BAT group in the dark blue, the middle in the light blue is the control group, and the lavender or purple is the difference between the two. So with 6-minute hall walk, we saw a net positive increase of 60 meters. This increase was statistically significant with a p-value of 0.01 and clinically significant as well. Looking at quality of life data, we saw a 14-point reduction in quality of life in the BAT arm. Notably, that reduction in the Minnesota Living with Heart Failure score is actually a positive, so a 14-point improvement in quality of life. This also was statistically significant with a p-value of less than 0.01 and clinically meaningful. And finally, with respect to NYHA functional class, 65% of the patients in the BAT arm improved at least one NYHA functional class. This compares to just 31% in the control group. This too was statistically significant. 94% of BAT patients improved in at least one of those metrics, and the authors defined a super responder rate in that patients responded either greater than 20% in the 6-minute walk or responded down to an NYHA functional class of 1 or improved by 10 points in the quality of life score, and 79% of patients met this super responder category. And finally, with respect to NT-proBNP, we saw a 25% reduction in NT-proBNP. This too was statistically significant at p-value of 0.004. So the strength of this pre-market 6-month data led to the FDA approval, and the post-market phase continued in order to assess long-term outcomes. And so I'll now discuss the post-market phase results. The following slides that we're going to walk through were presented again by Dr. Michael Zal at THT just about a month ago. These data have not yet been peer-reviewed or published in a peer-reviewed medical journal. So I want to make that clear. So what I'm going to do is walk through these slides. These are the same slides that Dr. Zhao presented in an abridged format. And I'm going to try to use some of the same verbiage to keep the messaging consistent. Access to the full presentation and symposium are available online. The slides that I'm going to show are summary slides. So on behalf of the Executive Steering Committee, the patients enrolled in the trial, and the study site personnel, it's my privilege to present the long-term outcomes of the BeAT-HF trial. BeAT-HF was a prospective, multi-center, randomized clinical trial, open-label, blinded evaluation. Patients were randomized into 2 groups, those with the BAT and a non-implanted control group. The study eligibility criteria are listed here. The trial was performed in 2 phases, as we discussed, a pre-market phase with 264 patients, leading to FDA approval in August of 2019. In the post-market phase, the primary endpoint was a composite of cardiovascular mortality and heart failure morbidity, and the additional pre-specified endpoints are listed here. Using an intention to treat analysis, a total of 323 randomized patients experienced 332 primary events over 1,036 patient years of follow-up, with a median of 3.6 years per patient. The baseline characteristics were well balanced between the BAT and the control groups. Patient had characteristics typical of NYHA class 3 heart failure patients. And they had the expected level of comorbid diseases, including coronary artery disease, atrial fibrillation, and type 2 diabetes. Heart failure treatment at baseline was well balanced between the 2 groups and followed the guidelines in place at the time of randomization. Especially noteworthy is the high frequency of the highlighted treatments. This was a well-treated cohort. The primary endpoint, again, was cardiovascular mortality and heart failure morbidity, assessed using a negative binomial model. Cardiovascular mortality was defined as cardiovascular death, LVAD, or cardiac transplantation, and heart failure morbidity was defined as non-elective heart failure hospitalization and heart failure emergency room visit. The additional pre-specified endpoints are listed here. In particular, we looked at a hierarchical composite analysis using win ratio, which I'll spend some time on in the subsequent slides. In addition, all-cause mortality, durability of safety, and durability of our patient patient-centered symptom improvement outcomes. This slide shows a top-line summary of key evidence from the beat heart failure post-market phase. And I'll walk you from the top to the bottom. There's a lot to digest here. At the top, from the primary endpoint and the components of the primary endpoints were not statistically different between the BAT group and the control group. In the middle, importantly, both all-cause mortality and the hierarchical win ratio were improved in the BAT group. The hazard ratio for all-cause mortality was 0.66. This approached statistical significance with a nominal p-value of 0.054. The hierarchical win ratio was 1.26. This was statistically significant with a p-value of 0.04. And finally, long-term safety and long-term symptom improvement favored the BAT group. These improvements were statistically significant when compared to the control group with nominal p-values of less than 0.01 across all time periods. So Dr. Zal and the steering committee came to the conclusion that the totality of evidence indicates that BAT is a safe, effective, and durable treatment for patients with heart failure with reduced ejection fraction. Now, the following slides were not included in Dr. Zal's presentation, but I've included them because I think it's worth spending a few minutes discussing the concept of a win ratio and the implications therein. So a traditional composite endpoint has some limitations in that all events are equally weighted. So mortality is actually weighted the same as a heart failure hospitalization. And in that, only patients who are actually experienced a heart failure mortality or a cardiovascular mortality or heart failure hospitalization would be included in the analysis building up to the primary endpoint. And this only represented 40% of patients in the BeAT-HF trial. In addition, the traditional composite endpoints do not include patient-centered metrics such as quality of life. So a win ratio analysis actually overcomes some of those limitations in that events are prioritized by severity. So a death is actually weighted more than a hospitalization. And it evaluates by pairing all patients in one arm to all patients in the other. It evaluates the experience of 100% of patients in the study and allows for inclusion of quality of life metrics. So this slide is busy, but I'm going to walk through it because it's particularly important to understand where this win ratio of 1.26 comes from. So each Barostim patient, 163 patients on the left of the slide, is compared to each patient in the control group. And literally, you walk through this decision treatment paradigm to figure out who is the winner. And this actually results in 26,080 pairs, and that's just math, 163 times 160. And so with each pairing, you ask yourself first, did one patient survive longer than the other? If the answer is yes, that patient is the winner. And if the answer is no, you ask the next question. Did one patient avoid LVAD or transplant versus the other? If the answer is yes, that patient is the winner. If the answer is no, you move on to heart failure hospitalization. Did one patient have fewer hospitalizations than the other? The answer is yes, that patient is the winner. And if the answer is no, the last question is adjudicated regarding quality of life. Did one patient have better symptomatic outcomes than the other? If the answer is yes, that patient is the winner, and if the answer is no, that patient is deemed a tie. And so you take the total wins for the treatment group, in this case the BAT group, in the numerator, you take the total wins for the control group in the denominator, and you do the division, and in this case the division gives you a win ratio or hierarchical win ratio of 1.26 favoring Barostim. So you can actually say that there were 26% more wins in the Barostim group than there were in the treatment group. There are several studies recently that have used win ratio as a primary endpoint. Notably here is the Triluminate trial, looking at the TriClip and severe tricuspid regurgitation. In addition, there are several studies that have reanalyzed their data looking back using the win ratio. Just a few are listed here, the Partners B trial for symptomatic aortic stenosis, Emphasis HF, looking at eplerenone versus placebo in the heart failure space, and then the Paradigm trial looking with sacubitril valsartan versus enalapril. And it's important to note, you see win ratios listed here. We really should not compare one win ratio from one trial to another because the calculations are different. I use these for directional purposes only. So in summary, as we discussed, both the primary endpoint and the components of the primary endpoint were not statistically significant between the BAT group and the control group. That said, all-cause mortality and the hierarchical win ratio were improved in the BAT group. The hierarchical win ratio was 1.26, suggesting that the overall clinical benefit was 26% more likely in the BAT arm. And both long-term measures of safety and symptomatic improvement improved in the BAT group. Importantly, we saw the symptom improvement metrics at 6 months withstand the test of time. And so, based on the totality of evidence, I do think it's reasonable to come to the same conclusion as Dr. Zeil and the steering committee. The totality of evidence indicates that the BAT is a safe, effective, and durable treatment for patients with heart failure and reduced ejection fraction. Thank you.
I just want to say how thankful I am that they chose Dr. Howard to discuss the win ratio. It's not one of my fortes. Also, apologies, I've recently graduated to readers, so I'm still trying to figure out how to see the audience stuff. So my name is Robert Cole. I'm the medical director of advanced heart failure at Piedmont in Atlanta, across town from Dr. Howard. And it's my pleasure to present our center experience with Barostim. We have about 47 implants so far. If you had asked me 3 years ago if I'd be discussing our center's experience with Barostim, I would have said probably not, because like many of you in this room, I was a skeptic. Hopefully, as you'll see, and sort of what turned me is, seeing really is believing, and seeing some of these patients really improve their quality of life tremendously, and in many cases actually remodeling. I think once you see it, you'll adopt it as well. I do want to highlight, let's see here, if this will go. There we go. We've talked a lot about quality of life. I think we do a great job with GDMT, which clearly improves mortality, heart failure hospitalizations, and things. But if you ask the patients if they could choose quality of life over quantity, many of them would choose quality of life. I think we lose sight of that. I think there's a lot of discussion, obviously, about the long-term BeAT-HF data. I will tell you, the 47 patients that we've implanted, we had no mortality data for. We did it to improve their quality of life. And I think if you view it as a quality of life improvement, many of your patients will buy into that. Obviously, hopeful for clinical improvements and outcomes, and I'll show you some of the outcomes of our first 30 implants for which we have 6-month follow-up data. This was shown already in our first talk, our fantastic talk. GDMT, obviously great for mortality, heart failure hospitalizations, all of our fabulous composite endpoints in our clinical trials. That being said, do very little for exercise tolerance, and as we know, patients, they want to feel better. I'm going to get in trouble for saying this, but class 3 heart failure sucks. Could you imagine if you had to get up and walk out the room and you were short of breath by the time you got to the door? I think we take that for granted. Minimal activity leads to shortness of breath. Patients want to feel better. As we alluded to, CRT can do that if you're in that small population of patients who has a left bundle, especially if it's greater than 150, and if you're a candidate for that, great. But short of that, we really don't have a lot of therapies for improving quality of life. And ironically, most of the ones that have shown improvements in quality of life are devices, not the medications, as you can see here. CRT, of course, indicated in that small population of patients. CCM also indicated for EF 25 to 45. And then you can see Barostim here. So I just reiterate, when you're thinking about your patients, yes, mortality is important. Yes, heart failure hospitalizations are important, but what's important to the patient oftentimes is quality of life, and that's where Barostim can really impact that. So a little bit about our experience, which is what I'm here to talk about today. If you're not familiar with Piedmont, we're a large healthcare system in Atlanta and throughout Georgia. We have 19 hospitals total. We have 5 cardiologists at our main hub. You can see we are an advanced therapy center. We do a lot of transplants, a lot of LVADs, a fair amount of cardiomems, and as I alluded to, we have about 47 implants, 30 of whom have 6-month follow-up data, at least some very basics. And we launched our program about 2 years ago. So, just for curiosity, I decided to look at our patients, look at our data, who are we implanting, what happens to them, because anecdotally, the patients that I referred did really well. And I wasn't sure if that was true across all the patients of the other cardiologists. So we looked at this. Again, our first 30 implants. You can see the general demographic of the patients, sort of typical late 60s, majority ischemic, interestingly. I think this is a really interesting category, CRT non-responders. Over a quarter of them were non-responders, and a few had cardiomems as well. Ejection fractions, 25%, mildly dilated, mildly reduced stroke volume, and you can see the NT-proBNPs here. The baseline New York Heart Association class, of course, indicated for class 3 or class 2 with recent class 3. We have used some off-label in some more advanced patients, which we can talk about another time, but we have had a few patients that are a little bit sicker. I was curious what kind of medications these patients were on, because we have a fair amount recently that are beta blocker intolerant, that is sort of a population I think can really benefit from this. But if you look, about half of the patients were on at least 50% or greater beta blocker target doses. All patients were on an ACE/ARB and ARNI, about 40% on at least 50% or greater. And then you can see MRA use and SGLT2 inhibitors. Pretty modest diuretic use in this population, the average equivalent of about 40 of Lasix. So what happened to our 30 patients? Well, as with any advanced heart failure program, some patients died prior to 1 year follow-up. The 3 patients, interestingly, that died, you can see really primarily died from non-heart failure, although you could argue that the third one here maybe. But this first patient had underlying interstitial lung disease and actually died of hypoxemic respiratory failure related to that. Interestingly, the patient's EF at 6 months had increased by about 5%, for what it's worth. This patient, our second one that passed, was really tragic, died of septic shock. He was what I would consider a major responder to the therapy. His EF improved by 15% at the 6-month mark. Unfortunately, went on to die of infection. And then our last one was an elderly gentleman who had a very poor quality of life and a lot of comorbid conditions, as with many of our patients. And as a bit of a Hail Mary, we tried to use it in him. Unfortunately, he came in with urinary retention unrelated, kidney injury, and did not want to go on dialysis and chose hospice. So that was an unfortunate, very short Barostim duration. We have had a few patients go on to actually need advanced therapies. 2 in particular went on to transplant. There's nothing like a 2 a.m. phone call. What do we do with the Barostim for this patient that's going to get a transplant? Do we turn it off? Do we take it out? Thankfully, we figured it out, but we did have 2 patients that went on to get a heart transplant. As you can see, though, it was not an immediate transplant. In fact, it was about a year before those patients went on to need it. I think one of my biggest fears was, what if we put this in an advanced patient and they deteriorate rapidly, and nobody wants to look like a fool, right? Similar to MitraClip, advanced patients, who's too sick, who's not too sick. So the patients that ended up getting transplant made it about a year with their Barostim prior to needing transplant. And then one patient actually very recently underwent LVAD after about 520 days of follow-up after his Barostim. So the patients that did go on to need advanced therapies during that first period, again, it was not an immediate effect so far. It was a good year to 2 years. So just looking at just a few clinical outcomes from our first 30, what about change in New York Heart Association class? This is not the prettiest graph, apologies, but this is sort of a baseline, and if it's down below here, it means patients got worse. If it is above, it means they got better. I recognize that it should be minus, not plus New York Heart Association. I think you can tell by the graphic, the majority of patients got better. 5 of the patients of these first 30 improved by at least 2 classes, 14 by 1. We did have 9 that had no difference. Again, like any therapy, not everybody is going to respond to this. We did have 1 patient that in the first 6 months got worse. Obviously, we had some others that after 6 months got worse. 3 patients that went on to get transplant and LVAD. But at least in the first 6 months, only 1. And then 1 patient was the unfortunate gentleman who died on day 16, so we don't have data for that. So overall, about 2/3 of patients had an improvement in this first 30 patient cohort, which was very reassuring to me because I was seeing my 5 or 6 that were doing well. The question is, what were the other patients doing? We only had echo data at 6 months follow-up on 21 of the 30. You can see the change in ejection fraction in these patients of the 21 that we do have data on. You can see a couple of patients really had a major response, 15-20% changes in EF. Overall, a little over half of patients had an improvement in their ejection fraction, which is obviously an interesting hypothesis-generating point. But there were plenty of patients who had no change, certainly 8 of them, and actually a couple that at 6 months had a deterioration in their EF. So again, as with everything, there are non-responders, but I think it's pretty impressive to see half of these patients, again, recognizing that these are patients that are already on their maximally tolerated GDMT. So it's not like these patients are getting a Barostim and GDMT titration simultaneously, although there are some patients that we do that with. And then lastly, something that we've really been interested in, because the patients who seem to get the most symptomatic benefit seem to have really impressive changes in their diastology, which makes sense, certainly changes in left atrial pressure. So we kind of wanted to look at this as well, change in diastolic dysfunction over the course of that 6 months by echo. And you can see, again, about half of the patients had improvements in their diastolic function. 8 improved by at least 2 grades. So those patients were class 3 down to class 1, or excuse me, grade 3 down to grade 1. Several that improved 1 grade, and then others that did not. So I think summarizing that data, and I'm about out of time, I think clearly in the first 30 patients that we've seen have seen some pretty impressive improvements. Obviously, not everybody responds. I want to just quickly highlight, I won't spend a lot of time on this. I said seeing is believing. I was not a believer until I saw these 2 patients. This first one was our second implant. A gentleman that really reduced EF 15 to 20%, had an ICD and a CardioMEMS, and was short of breath and really not tolerating a lot of GDMT, as you can see here, pretty minimal. And this patient, again, one of our first implants, really had a remarkable improvement. Class 1 symptoms, essentially asymptomatic, exercising, working out, ejection fraction improved, pro-BNP lower, and so forth. So this was sort of it definitely caught my attention. 2 cases later really just kind of blew my mind. And I don't want to overemphasize, again, there are plenty of patients, as with every therapy, that don't respond. But I think as you can see, these cases, all it takes is 1 or 2 for you to realize that there is a potential benefit. This patient was one of the most frustrating patients I think I've had. Really advanced symptoms despite extremely low BNP, normal ventricular size, grade 2 dysfunction, on modest GDMT. And this guy went on to have really a tremendous benefit, ejection fraction up. Can't get much lower in the pro-BNP, but anyway, so seeing those 2 cases as our second and fourth case really was eye-opening for me and my colleagues, to the point where we really have a treatment algorithm built in now that if there is a patient with an EF less than 35 on maximally tolerated GDMT and they are complaining, that is a patient that should be considered. And if there are no advanced risk factors, not anything concerning, we refer those patients for Barostim. In cases where the EF is severely reduced, or there are some high-risk features of the patient, very dilated, for example, we typically put them through CPSTs and right heart caths and use that as a fork in the road. If they're clearly sick enough, we go to transplant VAD evaluation. If there's reasonable peak VO2s and VCO2 slopes and reasonable hemodynamics, then we go to the Barostim path. And as you can see, in 3 cases a year later, we ended up getting the transplant VAD. But I think a lot of the patients that we implant are generated through this. So if you're at an advanced therapy center, when you're assessing those patients for risk stratification, if they fall out of that transplant VAD category, Barostim, I think, is an excellent option for them. Because we're out of time and we have one more fabulous speaker left, I'll just leave you with the conclusions. Class 3 heart failure sucks. I give my kids a hard time for using that word all the time, so I apologize. But quality of life is important to patients. Seeing is believing. You have to have some experience to see it. And again, if you're seeing advanced patients and they're on the fence, get some objective data and find that fork in the road towards transplant versus Barostim. With that, I will stop.
Okay, all right, we'll go ahead and get started. So my name is Patrick McCann. I'm a heart failure cardiologist in Columbia, South Carolina. These are some tough acts to follow, so I'll do my best to emphasize why we have built our neuromodulation program with Barostim in mind. These are my disclosures. This is a little bit of what our clinic looks like. We have a pretty good experience with heart failure, wide spectrum of disease. We work with LVADs as well as CardioMEMS, as Dr. Cole was pointing out. However, we are a non-transplant facility. We certainly have a multidisciplinary approach to our heart failure patients, utilizing pharmacists, social workers, APPs. With that, we function probably more as a clinical heart failure or a community heart failure clinic for our patients. And so I'll give you a little bit of our experience. Dr. Cole went through his experience, and ours has been similar. We've only been implanting since about November of 2021, but we've ramped up quickly because of the results that we have seen for our patients. So on this slide, there's a couple things. On the left side, you can see our patient characteristics for about the first 20 that we did at 6 months. We certainly weren't picking patients that were doing well, right? These are sick folks, fair amount of ischemic, class 3. And I like to point out the part about the GDMT there. We try as best as we can to optimize GDMT according to the guidelines and getting people on the Fantastic Four, as was pointed out earlier. However, that Fantastic Four is really difficult for them to show up all at the same time at max tolerated dose. So for our folks, they were on about 2.5 out of the 4 therapies. The results, however, were outstanding, and they were in line with what we saw with BeAT-HF, right? Reduction in NT-proBNP, improvements in NYHA, people are feeling better. And the other part here, I think that hasn't been emphasized yet enough, is the low risk of complication from the device, right? This is outside of any of the vascular places where we put all of our other devices. Very low risk for complications. And that's something that we really liked when we were starting to evaluate the therapy. We've seen this slide before. Dr. Grisette did a great job of going through the progression of the heart failure disease. We started probably implanting folks initially that were a little on the right-hand side of that second red line there, similar to what Dr. Cole had mentioned. Folks that we didn't have a whole lot of great options for them. They weren't tolerating therapy, maybe they weren't a VAD or a transplant candidate at the time, but had a very poor quality of life, just functionally limited, right? And that goes beyond just being symptomatic, right? It's one thing to be short of breath at the door. It's another thing to not be able to even enjoy any aspect of your life, right? And I think that's something that we sometimes forget about when we're treating some of our patients, focusing so much on their symptoms and their breathing, but can they actually get back to living? With the results that we saw in those early initial patients, and I'll go through a couple examples here in a minute, we've certainly started moving in between the red lines, just similar to what we've done with a lot of other heart failure therapies, whether that's medical therapy and moving into the class 2 folks, or even our LVADs, trying to get them implanted when they're Intermax 3. Earlier intervention is better. So our first case example is a gentleman would come in with his granddaughter all the time in a clinic. Really nice guy, but couldn't do anything. History of ischemic heart disease. You can see he's class 3. We tried to titrate his therapy as best as possible. He's on pretty minimal amount of medications. These are folks that you probably see in your heart failure clinic, and you do your best to get those meds up, but they start coming in with lightheadedness, dizziness, not tolerating therapies, whether it's impacts in renal function or hyperkalemia from some of their MRAs. But he just kept getting hospitalized, and he felt terrible. He couldn't do anything. And you can see there, a 6-minute hall walk, 30 meters. The guy would get dizzy, get lightheaded, have to wait, start up again. We discussed a lot of options with him, like we do with all of our patients, right? Trying other therapies, whether that's ivabradine or vericiguat, or considering inotropes and LVADs. But at 83, he's really looking more for quality of life. And as Dr. Cole pointed out, that quality of life is incredibly important, but it's also incredibly important as we get a little bit older. And if you've seen enough patients, when they start to get into that kind of 70s, mid-70s or older, they're focusing on quality of life. They want to be able to do things, not just live longer necessarily. And I think that's very important for us to start recognizing sooner rather than later, especially with the age of our population increasing. So we put a Barostim in him. We titrated over about 4 months. We did a little bit of slower titration back then because he was one of our earlier implants. And since that time, he's not been hospitalized. You can see his 6-minute hall walk there. But more importantly, he has come back into the clinic and expressed just how much he is enjoying life. One of his big things was gardening. He's able to go out into the garden, enjoy planting all the things that he likes to in the spring, which he hasn't been able to do, and that gives him great joy. And to us, that is a huge benefit to the patient, and his granddaughter thinks so as well. The second example here is a gentleman that was probably a little bit further down in the progression of his heart failure. Came into me, had been seen previously, referred for advanced therapies. We talked about BAT, inotropes, did his right heart cath, put him on a little bit of milrinone for a while, and he felt great. Had an excellent response, really good blood pressure response. We started titrating his GDMT. Didn't tolerate a little bit because of UTI, and then because his blood pressure started dropping, we successfully weaned him off inotropes. And he did okay for a little while, but then he started dwindling. And we've all seen those patients, right, that start to have a little bit of heart failure, a little worsening, can't quite get up the driveway now, and he was becoming much more frustrated because he didn't feel as well. We talked about advanced therapies again, and he doesn't want them, right? That's just not what he wants for his life. He doesn't want a driveline, he doesn't want batteries. And he was very frank about it. He said, listen, I'm not looking to live another 10 years. It's like, if I could just feel better, that would be great. So we talked about Barostim. We said, hey, I don't know that it's going to make you live longer. By the data, there's a good chance that you'll feel better. And he was agreeable, and we had that discussion. We went ahead and implanted, and you can see our titration was a little faster. Because after a month, when he came back in to talk to me, he said, okay, you put this device in me. I don't feel any different. What's going on? I said, okay, well, I'll pump the brakes here. Hold on. We haven't even titrated the device yet. And he said, well, can we get this thing moving along quicker? I said, sounds good. Let's try and do that. And I think that's one of the big things with heart failure. When you're treating it, we live in a gray area, right? You got to be open to ideas. You got to kind of dwell in the ideas of possibility and what you can do. And so we moved his titration along a little faster. And after we were finished with his titration, you can see a 6-minute hall walk. He hasn't had any hospitalizations. But again, he's living. He's traveling with his wife. Big thing for him was taking care of the yard was always his responsibility, and he couldn't do it. Now he puts on his blower, he's blowing his yard, he's mowing his lawn, he can walk up at his driveway, which is up an incline. He is enjoying life again. This is our titration strategy now, and we will probably actually increase this in the last 3 that we've implanted, we're starting to do this on a weekly basis. Certainly it worked at every 2 weeks of increasing. And what we do is we'll bring them in, titrate their device, and we don't really make much in the way of titration of their neurohormonal blockade at that time. Most of these patients have already been titrated to their max dose by then, but we do adjust diuretics. That's certainly something that we've noticed in our experience, is that they have an increased volume loss early on, and so you have to adjust that with the diuretics to avoid any lightheadedness. And then after they're completed their titration, they still have room, which that's been another benefit that we've seen, is a stabilization of blood pressure, if not actually a little bit of an improvement. Then we will continue to titrate GDMT. And then we finish usually by getting the repeat 6-minute hall walk and a follow-up NT-proBNP. With that, I think there's some things that we have to talk about in heart failure, and there is a significant unmet need. As Dr. Grisette pointed out, we have come a long way with GDMT. The challenging part is what you saw in Evolution-HF. People don't want to take a whole bunch of medications. We talk about the Fantastic Four, the 4 pillars, whatever you want to call it. You add that into somebody that has diabetes and ischemic heart disease, suddenly that person's on 8 to 10 medications. That's very challenging for somebody to get up every day and take 8 to 10 medications at multiple times throughout the day, and it's not a surprise that they discontinue their therapies. Also not a surprise to what Dr. Cole mentioned, that device therapies tend to do a little bit better there. Adoption of Barostim allows you to expand your therapeutic approach. It's important, right? You get another tool in your toolbox to utilize for those patients, and I think earlier intervention is certainly where we need to go with these patients. As Dr. Cole pointed out, and in our experience as well, it's going to work better for your patients overall, even if that is maybe slowing their time to transplant. Again, less therapies that they have to be on and a better quality of life. Anecdotally, we have seen reduced hospitalizations in our patients, and I'm excited to see what comes of that as we continue to move forward with our program. But patient selection is critical. Earlier intervention, optimizing the GDMT is still very important, but this device should be utilized more frequently for our heart failure patients. Thank you.
Are there any questions from the audience?
Thank you for the wonderful presentations. You're all very talented speakers. I appreciate that. I'm curious as to what you did with the device at the time of transplant. Are you allowed to tell us?
I think so. The patients still have them in place. We titrated them down or off. The first one, I think we just titrated down to 1 or the lowest we could think of, and they got through surgery then. But the devices are still in. Both of the patients are still within their first year post-transplant. So probably after year 1, we'll discuss ways to just have it taken out. We just don't want to rock the boat right now. But, so they're not getting active therapy, but
I actually have a question while the audience is pondering. So Rob and Pat, you guys both have talked about your experiences, which I appreciate. I too have a Barostim program, a little bit smaller than you guys, but I was an early adopter of this therapy because I saw exactly what you guys have seen for many of the earlier patients, and we've continued to implant during the commercial use. The question I have for both you guys, actually, I talked about super responders seen in the BeAT-HF trial, and you guys have talked about these kind of quote-unquote super responders that get down to NYHA class 1 and the EFs come up, and it's just clear that the device has helped them in a way that you would not have necessarily foreseen or even hoped for. But now that you've seen it a couple times, maybe you hope for it for everyone. Do you guys have any insight on who that patient is, or when we're trying to find these patients that the device is going to help, do you have any insight on who is most within this NYHA3 functional class that's optimally titrated on meds and not a class 1 indication for CRT? Who are the patients within that bucket that are most likely going to respond the best? Do you guys have any insight on that?
Sure, I can take that a little bit. I think one of the challenges is looking at EF, right? EF and heart failure has sort of become like the troponin in cardiology. because there's so much more that goes into it. And what we have noticed is the patients that have had some of the best response, probably their cardiac index, the bottom cutoff would be somewhere around 1.6. What we have noticed, so initially when we started with the therapy, we had outstanding responses for patients, and some of them we were able to get off inotropes. I certainly don't think that's where you should start with it, but we didn't have the experience, and nobody else really had a whole lot of experience at that time either. And what we've learned is that if their cardiac index is too low, they're probably not going to thrive, right? They do okay, to what Robin pointed out. They still get benefit, but they don't thrive. And from our clinic standpoint, we're not in the habit of providing therapies unless people are going to really get great benefits. And so that's what we've started to see. If the cardiac index probably less than 1.6, I don't know that those patients are going to thrive well with the device. Above that, they seem to do very well, and I think that's going to be our cutoff a little bit. We've talked about that in terms of the development of our program is probably investigating what their output and index is by right heart cath.
Yeah, I have no idea. It's that's been sort of the mystery, and honestly why I've started looking at our data. Hopefully, be able to figure that out, and certainly compile data with you guys and try to figure out who are the responders, because I have not been able to predict big ventricle, little ventricle, high EF, low EF, for better or worse. But I do agree that there's sort of a, in general, sort of a too late as with any therapy. That being said, we have also off-label weaned somebody off milrinone after Barostim as well. So I think that, from my perspective, at least the patients that I've seen, I'm not really sure yet. I'll be fully honest.
And I think even though, both of us are probably unsure, that's just certainly observational, but I think the important point there is we're seeing similar benefits for our patients.
So Dr. Howard, what's your experience?
So I agree with essentially everything that everyone said on this panel. It's been interesting to hear Rob and Pat's experience, because it's very similar to mine. In fact, I'd not seen Dr. Cole's slides before he presented them, but the algorithm that he showed and the treatment paradigm that he uses to decide who goes towards Barostim versus VAD transplant is exactly what I do in my head. And my experience, just like Dr. McCann said, there is, there are always going to be anecdotal kind of experiences that really are more favorable than what you predict. But in general, you want to get these patients before they're actively dying, because when they're actively dying, the best evidence for long-term survival is going to be VAD or transplant. But there is a large cohort of patients that they're not actively dying, but they're not thriving, as Pat said, and I think that's where this therapy plays.
Good afternoon. My name is Rose. I'm from the University of Pennsylvania. This is really interesting and exciting findings. When you're talking about multidisciplinary care, who is implanting this? Is this EP? Is this general surgery? Is this vascular? Who are you partnering with?
Yeah, at least I'm guessing it's probably similar. We do have a vascular surgeon that is our primary implanter. The EP doctors sort of work with him, but really it's the vascular surgeon. One of the slides that I skipped through of sort of learning points was if you can have more than one surgeon do it. We've actually now our transplant VAD surgeons are going to be doing them as well. So I guess if things go wrong, they can just stick an LVAD in the OR. But so we're going to have multiple surgeons do it now. There's some future iterations of the device that'll be less invasive, I think, or at least that are being studied, where it'll probably be more EP driven. But we've got vascular surgeons and now.
I also imagine there's a vascular evaluation that occurs before this gets implanted.
Yeah, just a carotid Doppler is all that.
And can you speak to the durability of these leads? The neck is very mobile as opposed to a typical pacemaker lead that comes across the chest.
Yeah, I think sifting through at least the 30, some of who I don't even know, but there was one case that had some lead dislodgement issue, but the rest, it has not been an issue. I don't know if you guys have experience with that. Dr. Rizzo, yeah.
From our experience, we haven't had any challenges with the leads as far as neck movement. I think we've had one case where we brought her back to the clinic because when she got home, she started feeling a little bit of the stem, and we just came in and turned it down a little bit. That's really about it. It's very well tolerated in the clinic as far as the titration. It's very simple. I think the important part of growing it is having the upfront evaluation, NT-proBNP and the carotids get done. And then we've had the benefit of having our VAD surgeon implant them. So he's familiar, with heart failure, and he's got a lot of experience with vascular surgery as well. And it's been pretty smooth.
And this
overall.
hasn't interfered with the right heart caths or biopsies in the future, replacement of swans
No.
for ongoing care if they decide to tank and go left and head down the pathway for advanced therapies?
Yeah, I think it has not altered it. I think some of my colleagues have gone on the left IJ just for safety purposes. I've done a couple of right IJs. Just have to be careful though. Yeah.
Thank you very much.
Yeah.
One comment I want to add for those who aren't particularly familiar with the therapy, the concept of stimulation. So one of the reasons you can't just increase the therapy up to max dose straight away is the patients can and will feel stimulation from the neck from the device. And so when you implant the device, it is turned on at a very low level, and then slowly but surely, as Dr. McCann mentioned, you increase the output over time to get up to a therapeutic level. And by doing that slowly but kind of consciously, you can minimize the likelihood that they feel stimulation in the neck, because it is, I've never felt it, but they describe it as an uncomfortable sensation.
And one final comment, there is an ongoing study looking at a transcutaneous approach where the lead would be tunneled, which would basically be something that would be managed by an electrophysiologist. But we also do joint implants with a vascular surgeon and an EP doc.
Hello. Yeah, I just actually a couple more practical questions. So in terms of long-term follow-up, are these patients followed in the device clinic? Are they followed, in a special clinic? And then my second question, completely unrelated, reimbursement, has that been an issue? Are you getting paid for these? And is the reimbursement adequate to cover costs?
So as far as the reimbursement portion of it goes, my hospital wouldn't allow us to do it if we weren't, if it wasn't adequate, certainly from our standpoint. So that's been sufficient. When there's been troubles in the past with other devices, the admin quickly comes to us and tells us if there's a challenge. They've embraced it completely, and so there hasn't been any problems from a reimbursement standpoint from the Medicare patients. The commercial insurers, it depends, insurance to insurance. The other part for the follow-up, that's been one of the best things for the follow-up as far as we're concerned. We bring them into the heart failure clinic, we titrate them. Once they're done with their titration, it's kind of a set it and forget it a little bit, and they have their 3-month or 6-month follow-up. It's been wonderful to do that. They don't have to keep coming back for their continued titration, and that's part of why we want to start moving this along a little bit quicker for those folks so they get the benefits sooner and they get back to living.
Similar reimbursement. There were some issues along the way, but we sorted them out. Similarly, our administration came and said, "Hey, we see something here," but it turns out we were not billing appropriately, and we sorted that out. But our patients also, they just follow up in our heart failure clinic. It's almost as if the EP, I don't know that we even need the EP. We have the vascular surgeon and the heart failure clinic. I always CC the EP guys when I'm sending a request, but I think until the next iteration of the device is transcutaneous, their role is a little bit limited.
The reimbursement question is definitely one of mine as well. But are you guys implanting these inpatient, outpatient? What's kind of the post-implant follow-up look like?
Yes.
Yes,
So
the
we do
mix.
outpatient and inpatient. We're much more aggressive about it now than we were previously because of the results. But inpatient and outpatient can both be accomplished. One of our limitations for the inpatient is the availability of our surgeon. We're excited because we have another one coming that's going to get trained in it, so we think we will increase our volume a little bit more. But the follow-up for us, we still keep them a day. I don't know if you guys keep them over a night, and it's been more out of a concern from our surgeon, just wanting to make sure, because it was a newer device. I think we were certainly at a point where we can send them home the same day. Nothing ever happens with them overnight, other than we come in and they tell us how much they're going to the bathroom. And
Yeah, similarly, I think it's nice the reimbursement piece is not as much an issue as with some other devices like CardioMEMS, for example, where you really like to be able to do pre-discharge CardioMEMS. But so we have not had the same. We've done mostly outpatient, but I think as we become more comfortable with it, probably more inpatient. Yeah.
And we started, so we've done all elective procedures planned, so the patient walks in from home. We were initially, probably the first 4 or 5 we did, we were keeping people overnight, kind of just the surgeon wanted to, just to feel comfortable, but nothing was ever happening, everything was fine. So the last probably 10 or 15 we've done have all been, they've gone home the same day. We've had no issues, as Dr. McCants mentioned, and as I mentioned, this is a very safe procedure. I mean, when you compare it to something like the LVAD or transplant, it's a no-brainer.
Thank you.
I think we have time for this one last question, and then we have to wrap up.
Thank you. Thank you, everyone from the panel. Outstanding lectures for everyone. I'm Jose Ruiz from Mayo Clinic. I had a question for Robert. You said that you had an algorithm regarding going through the transplant route or implanting the Barostim. But you mentioned about cardiopulmonary exercise stress tests that you go by is on the numbers. And right heart cath, any specific area that you go, and to the rest of the panel, if they do anything similar to algorithm regarding who goes for us?
Yeah, I think we don't have specific cutoffs per se. I think each one is sort of individualized. I think certainly profoundly reduced peak VO2. We're not doing them typically less than 12, or an index less than 1.8. I know you guys. Sounds like we need to lower our index, but generally 1.8 or above, and ideally above 14 on the CPST. But there's certainly some patients in that gray zone. But if below 12, below 1.8, we usually sort of push down the other path.
Thank you.
Agreed.
Well, thank everyone for attending, and I think we're going to wrap it up now and have a great ISHLT 2023.